Hi, my name is Brian Guerra. I am a professor of radiology at the University of Vermont College of Medicine and director of ultrasound at Fletcher Allen Healthcare, as well as director of the research programs in the Department of Radiology at the University of Vermont. I'm going to be speaking to you today about clinical elastography and elasticity imaging and the variations and applications it can be used for. Today I'm going to talk to you about clinical elastography and elasticity estimation using both ultrasound and some other modalities. Elastography and elasticity estimation have their basis in the ancient technique of tissue palpation, which is very ancient. It was practiced by the ancient Egyptians as early as 2600 before the Christian era. Organs that are commonly palpated include the liver, spleen, thyroid, neck, breast, prostate, aorta, scrotum, and extremities. The physics of palpation have been recently reviewed, at least briefly, by Timothy Hall in 2003. To be palpable, it's easy to think of it as an object simply must be harder than the tissue surrounding it. Otherwise, you won't be able to feel it. This is a technique that I use to qualitatively estimate the hardness of tissue. I call it echo palpation, and what you're seeing is I'm having a gel standoff on the patient's skin. This is a lump in the patient's groin, and I slide the paperclip over the palpable lesion. You can feel the edges of the palpable lesion through the paperclip, but you can also get an idea of how hard or soft the lesion is. If the lesion squishes like a sponge, then it's soft, such as this lesion here, or if it moves as a unit, then you would say it's a hard lesion. So this is a good example of a technique I use both on soft tissue masses and in the breast. Elastography is the imaging of tissue hardness rather than using standard ultrasound. It's more sophisticated than sonopalpation or echo palpation, which I just showed you. Ultrasound elastography is an outgrowth of tissue motion tracking techniques, which were originally presented, as I remember, back in the early 1980s. It began with M-mode tissue motion tracking, and then there were some Doppler tissue motion tracking algorithms, and then even later than that there were speckle tracking algorithms. These methods all sort of coalesced into two types of elasticity imaging, one called sonoelasticity, which has been primarily developed and promulgated at the University of Rochester, and static ultrasound elastography, which was developed in 1990-1991 by Jonathan Ophir and his associates at the University of Texas. MR can also be used to perform elastography, and in fact, any method that can image tissue and image changes in tissue position can be used. This is an example of an MR elastogram. The image on the left-hand side represents a displacement image showing waves of compression or shear waves traveling through tissue. And on the right-hand side, you can see an image of the reconstructed lesion based on the waves that were measured on the left-hand side. So MR is a very good quantitative method, and you can get a rough estimate of what we call the shear modulus, which has a direct proportional relationship to the Young's modulus or compression elasticity parameter for tissue using this technique for MR. Other methods that can be used include CT elastography. I have published, along with some other folks at the University of Vermont, a basic CT elastography technique that was used in the lung. Optical coherence tomography can be used. There's some variants of elasticity called, including Poisson's ratio imaging, which is basically a measure of the compression or axial strain versus the lateral strain, which we'll be talking about a little later. Non-imaging quantitative methods are also something we'll be talking about. We generally create images and try to estimate elasticity from the images, but there are some non-imaging devices. Elasticity imaging has grown by leaps and bounds from a purely research technique just a few years ago to now reaching clinical relevance, with at least 4 major ultrasound manufacturers now either having the product on the market or planning to. You can see on this slide the various companies that have been involved, the largest company being Siemens, with 2 systems having elastography on the market. Ultrasonics doesn't have their system on the market yet, but they have now licensed the technology and are planning to release it to the market very soon. Hitachi and Medison are other companies that are already on the market with products. Well, let's talk about what organs can be examined by elastography. It's usually best for a regular elastogram if you can apply pressure, because that's how we create an elastogram. We take an image, and then we press slightly and take a second image, and we compare the 2 images to get an estimate of displacement, and from the displacements we get a strain value. The organs that are most amenable to compression are superficial organs such as the breast, scrotum, thyroid, and any subcutaneous tissue. Deep organs are also accessible. Those who practice ultrasound know that you can compress the uterus, ovaries, prostate, and kidneys by external pressure. It just takes a little more pressure. Organs that are subject to physiological pressure, such as the lungs, heart, mediastinum, can also be imaged, because that physiological pressure caused by pulsating arteries or respiration can be used to create an elastogram. And any organ can be used if we use radiation force methods, which is something we'll be discussing briefly later as well. This is just an example I have created showing how I can compress the pancreas, which is shown on the left-hand slide, and the right kidney, which is shown on the right-hand part of the slide, showing that the kidney both displaces and flattens out slightly in response to the pressure. That is more than sufficient to create an elastogram or a strain image of the kidney and pancreas. So the message behind all of this is that any organ can be examined using current elastographic methods. There are different problems that you run into with various organs due to motion, out of plane, and other causes of noise, but basically the technique can be used anywhere. Now let's move to some specific applications. Just a listing of applications here on the next 2 slides are palpable masses such as cancers, nodules, nodes, things like that. Diffuse organ diseases also produce changes in stiffness of tissue and are amenable to elasticity imaging, but the difficulty of that is that elastograms are subjective and they're relative images, and you may not see anything if the whole organ is uniformly increased in stiffness. There are ways around that we will discuss. Muscle contractility is another area that's been studied fairly extensively, and muscles can be imaged readily, as well as can be the myocardium and blood vessel walls. Additional applications include evaluation of atheromatous plaque for soft areas in the plaque that might represent vulnerable plaque that could result in a vessel thrombosis. Venous thrombosis can be evaluated. The age of thrombi change their stiffness and can be imaged. The vessel walls may be imaged as well. Monitoring of ablation therapy is a very opportune method because ablations always produce much markedly increased stiffness of tissue, and since imaging modalities have difficulty imaging the ablated tissue reliably, elasticity imaging may be the solution to this problem. And finally, monitoring of interstitial fluid movement, such as in various types of edema. So now let's review some of the specific applications. Breast mass evaluation was the very first application that achieved some popularity using elasticity imaging. They're superficial lesions, so they're easy to compress. Breast masses are known to be hard when they're cancerous versus the softer benign lesions, and it's a disease of both medicinal and political importance. The initial work was performed by this system you see in the picture here, with the patient in the erect position. You can see there's a mammographic machine on the right-hand side of the image with a transducer clamped to a compression device mounted to the mammography machine. Our early elastograms were performed in the erect position so we could do a cranial caudal mammogram and do an exact correlation with the mammogram. This is an example of after we had moved to supine positioning. We mounted a bar on a table and put the positioning device there, and we did compression against the chest wall, which turns out to be a much better solution. The problem with erect positioning is that you can't get close enough to the chest wall to image many of the lesions, but supine positioning allows all lesions to be imaged. And we've since moved from using a computerized or computer-controlled stepper motor to provide the compression to handheld compression, which also works quite well. Here's handheld elastography on a chunk of steak and then also on a real patient, showing the typical technique where you rest part of the forearm on the patient and apply a very, very mild or gentle compression to the tissue to perform the elastogram. Typically, the amount of pressure applied is almost imperceptible to the patient. We only need less than 1% compression of the tissue, so the images actually don't look hardly any different from one another, the pre and post compression images, and the patient hardly can feel it. So it's a very, very gentle procedure. This is an example of a real-time elastogram performed handheld courtesy of Tim Hall. And you can see the lesion being compressed very, very gently on the sonogram on the left-hand side and the elastogram resulting from this compression on the right-hand side. This is a benign fibroadenoma. This is a more recent elastogram of a invasive intraductal carcinoma. You can see the irregular, sizable dark mass in the left-hand image, shown right here, and the cancer on the sonogram right here. Now, this cancer is not a real diagnostic issue. It's pretty obvious from the sonogram that it's a cancer, but there are other situations where the elastogram can provide significant increased specificity. Since our original work and our original publication in 1997, where we only had about 40 cases, we have many more now. And this shows a plot of the difference in size between the elastogram lesion and the sonogram lesion versus the hardness score on a 5-point scale. And what you can see is that there's a fair amount of overlap in lesions, but there is approximately 15% of the lesions that are separable using elastography. And these are benign lesions that we're talking about. So when we use elastography, we're often talking about diagnosing benign lesions and avoiding biopsies. All the lesions on this plot, of course, were biopsied because they were considered suspicious by sonography, and approximately 15% of them could have been eliminated using elastography according to the plot here. The yellow line represents the line of discrimination between benign and malignant that you would want to use if you were using elastography to diagnose these benign lesions. The diamonds are the cancers and the little pink squares are the benign lesions. On this slide, a new method to add specificity to the regular elastogram is demonstrated. This is a method of imaging the amount of shear strain that exists at the boundary of a lesion. Lesions such as a cancer, which are anchored to the surrounding tissue, do not have a free slip boundary and show up as an area of larger shear strain over a broader area. So if you look at the left-hand side of the image, that lesion in that phantom is bound to the adjacent phantom material, and you can see that the areas of shear strain at the boundaries are broad and rather indistinct. whereas on the side where there's a slip boundary and the lesion's not attached to the surrounding tissue, the areas of shear strain are very thin and sharply demarcated. We think we can use this feature to add specificity to the diagnosis of breast cancer using elasticity imaging, as this feature is quite independent from the overall stiffness of the lesion and the size of the lesion. So, to summarize breast elastography, will it have a role? Well, what about lesion detection? One problem with elasticity imaging is that on any given image you may see many or several dark areas which all could be cancers, so there may be a problem with false positives. Until recently, real-time display has not been possible, which limited its use as a screening tool. But perhaps all of these issues can be overcome and it can be used as a detection tool, but not at the current time. Right now, breast elastography primarily is a mass characterization tool. So the mass is identified using mammography and ultrasound, and then the area is examined using elastography and increased specificity results, hopefully from the elastogram, being added to the sonogram. The things that are required for characterization, I think you need to use video cine loops to look at the entire elastogram rather than a few static images, and real-time display is definitely desirable. Quantification may be helpful in the future to further increase specificity. The problem with breast elastography is that there are many competing modalities. You have MR, you have infrared imaging, you have advances in plain ultrasound and in mammography, tomosynthesis, all compete against ultrasound for diagnosing breast cancers. And it's not clear that elastography will emerge as a dominant player. But since it can be performed at no additional cost as part of the breast ultrasound, which is already a major component, we believe that it will be a useful addition and will gain a competitive advantage in that way. Moving on to thyroid cancer. Thyroid cancer, at least in my clinic and a lot of others, is the most common reason we do an ultrasound-guided biopsy these days. Many patients have large numbers of nodules, and this is a big challenge because the current criteria, which calls for biopsying nodules primarily based on their size, has no real firm foundation. And oftentimes smaller nodules are the cancerous ones and the large ones are benign. And what do you do with a patient with 20 nodules? You can't really practically biopsy all of them. You may have to biopsy one or two, and we need a method by which we can decide which nodules that are more likely to be cancerous. Initial elastography results published by Andrei Lychik in Radiology in 2005 are promising, showing that if you use a strain index greater than 4, with the strain index being the strain in the lesion in question versus the strain in adjacent thyroid tissue or muscle, you can achieve reasonable sensitivity and specificity. And if you combine that with tumor area ratio, you can increase that slightly further. Here's an example of a thyroid elastogram, courtesy of Dr. Lychik, showing a benign nodule outlined on the left-hand image here, and the benign nodule on the elastogram here, showing that it's only minimally more stiff than the adjacent thyroid tissue, right here. The cancer, on the other hand, outlined on the left-hand slide here, shows up as quite a bit darker or harder than the adjacent thyroid tissue, and this may be a useful way to determine which nodules to biopsy. Like thyroid nodules, lymph nodes are also a problem. One of the most common sites of tumor involvement include lymph nodes. They're present in all areas of the bodies, including superficial areas, and a lot of these superficial nodes are biopsied. Again, if there's multiple nodes, it'd be nice to know which nodes are most suspicious so we know which ones to biopsy. An example of benign nodes is shown here. The lymph nodes on the sonogram are shown on the left-hand slide and on the right-hand slide. you can see that the lymph nodes are relatively soft, showing a large strain value, which displays as bright on the image, suggesting that they represent benign nodes. Period. Their shape is also suggestive of benign lymph nodes. These nodes, however, are more rounded, which might be suggestive of malignancy, although that's not a reliable criterion by itself. On the elastogram, however, you can see there's an area of increased stiffness in the region of those lymph nodes, making them suspicious for cancer. So the potential for lymph node elastography is quite great. It's a common technique to biopsy lymph nodes, and knowing which ones to biopsy would be very useful. It possibly can be combined with PET-CT and regular V-mode ultrasound to create a powerful comprehensive tool for metastatic malignancy diagnosis. Prostate cancer is another area that can be examined that elastography may be of help in. Prostate cancer was actually the first type of lesion that was imaged using elastography back in 1990-91. And the current methods of diagnosing prostate cancer remain an elevated prostate-specific antigen, or PSA, plus random biopsies of the prostate gland, with the biopsies being guided by ultrasound. This random technique works pretty well, but is quite invasive, and we don't yet have a reliable imaging tool yet for prostate cancer, though high-field MR appears to be a promising tool that hasn't been fully validated yet. Prostate nodules are hard to palpation, and here on this sonoelasticity image provided courtesy of the University of Rochester, we can see the normal prostate gland showing up as green and the hard prostate nodule showing up as darker. This is an example of one of our early prostate elastograms showing normal anatomy. There's no cancer here. This is the verumontanum, and you typically see this cross pattern occurring in the prostate gland. This dark area was not cancerous and suggests that, like all elastograms, it will have to be viewed in conjunction with another modality to increase its specificity. Here's another example of a prostate cancer courtesy of Ramesh Sushan from France, showing the lesion on the sonogram and the hardness of the lesion on the elastogram. And yet another lesion, more recently imaged courtesy of Kaiser Alam at Riverside Research Institute, showing a small prostate cancer showing up as a small, dark, hard area on the elastogram, and not really showing up on the sonogram. Well, what is the potential for prostate elasticity imaging? There are image quality challenges due to the fact that prostate imaging probes are very tightly curved, making it hard to apply uniform pressure to the prostate gland. But these problems may be solvable. Prostate cancers may vary in stiffness. Some cancers are harder than others, and that's a problem that means that probably elasticity imaging will not be able to reliably image all cancers. But continuing work at Riverside and elsewhere suggests that if you combine elastography with other features, perhaps even high-field MR, the identification of cancers may be quite reliable. And of course, it's a great method for ablation monitoring if you decide to treat the prostate cancer with ablation rather than surgery or radiation. Well, diffuse organ disease is another area where elasticity imaging probably plays a great role. There are many diffuse organ diseases, and I've listed a couple of the processes and what they might be expected to do to the tissue. Edema and necrosis, or decay of the tissue, would produce softer tissue, whereas inflammation and fibrosis will tend to produce harder tissues. And a couple of examples include rejection of a transplant, which is harder than a normal transplant, and hepatic cirrhosis, which also produces increased stiffness in the organ, the liver. There's a non-imaging device that has been extensively studied for evaluation of liver cirrhosis. That is the FibroScan produced by a French company called Ecosens. This transducer is placed up against the abdominal wall between ribs, and a pulse of ultrasound energy is sent into the liver to image the change in liver caused by the vibration of the transducer. So the transducer does a mechanical vibration that transmits vibration waves into the liver, which produces shear waves. The ultrasound beam then follows and images the shear waves, and from the images or analysis, it detects the velocity of the shear waves and then calculates the stiffness of the liver, or the shear modulus, denoted in the equation as E. This device has been extensively studied mostly in Europe and elsewhere outside of the United States, and is showing very good performance with an area under the ROC curve of 0.94 for cirrhosis and a high sensitivity and specificity. But it doesn't seem to work quite as well for lesser degrees of liver fibrosis. MR can also be used to evaluate for liver cirrhosis. The MR also uses shear waves, which travel quite slowly through tissue. A vibrator is placed against the liver, and then a pulse sequence that is sensitive to phase is used to help image these shear waves as they traverse the liver. The speed at which the shear waves travels is directly proportional, or proportional to the shear modulus within that tissue. And you can see the difference between normal and cirrhotic or fibrotic liver shown on this slide. Diffuse renal disease and elasticity imaging should be a fruitful area for further study. Pyelonephritis, interstitial nephritis, and glomerulonephritis are all entities that are hard to image and where elastography could be helpful. Renal transplants also develop processes that are amenable to elastographic imaging, including rejection, acute tubular necrosis, and fibrosis caused by chronic rejection. This is an example from a paper that was recently published about whether you could see the compression of a kidney by external compression, and in this case it was used to evaluate normal versus abnormal. The average strain in one patient with chronic rejection was approximately 1/3 of that in a patient with a normal transplant. So even a crude method like this, where they're simply measuring the shape of the kidney and whether it flattened during compression, has proven useful for diagnosis and suggests that elastography in a more advanced form would work to help diagnose rejection. In the uterus, several things can be studied. Endometrial tumors can be evaluated, primarily to distinguish between cancers, polyps, and fibroids. Within the myometrium, fibroids and adenomyomas could be monitored. Perhaps it could be used to grade the severity of adenomyosis. It's not clear whether adenomyosis will produce increased or decreased stiffness of the myometrium. This entity remains to be studied. And there's been some recent work on uterine changes during pregnancy suggesting that softening of the cervix, which is an indicator that the woman's ready to deliver, may be studied using elastographic imaging. So the potential, in summary, for diffuse organ disease is that it's got great potential. The advent of quantitative methods for strain estimation, such as the shear modulus estimation, means that you could possibly use elastographic evaluation to replace a number of the liver biopsies. Also, imaging can help with grading of severity and also identifying areas that are more involved than others. Many diffuse diseases do not involve an organ uniformly, but involve it asymmetrically or in patches, and this can be useful information in helping to determine what therapy is appropriate for a patient. In the cardiovascular system, strain imaging has been performed for a very long period of time. They use somewhat different techniques because these organs produce strain as a normal course of their process of contraction. For strain imaging of the myocardium or heart, evaluation of areas of ischemia and infarction can be evaluated using strain imaging, showing less strain in the areas of infarction and ischemia. Arterial walls can be evaluated, but more particularly atheromatous plaque can be evaluated to look for areas of vulnerable plaque which are softer than normal plaque and should appear. This is an example of a vulnerable plaque or soft plaque that was imaged using strain imaging. The area pointed out in the arrow in yellow is an area of increased softness on the strain image, and it correlates with an area of vulnerable plaque on the histology. So the potential for cardiovascular strain imaging is pretty high. However, there are a number of methods that compete with strain imaging for evaluation of infarcts and other abnormalities. In addition, all the real high quality images of vessels have occurred using intravascular imaging, which is expensive and very invasive. So a method for performing strain imaging from external to the vessel without having to insert a catheter will be required for this to really become popular. Ablation monitoring I've already mentioned. There are many ablation therapies available, including radiofrequency, cryoablation, chemo, laser, and high-intensity focused ultrasound. All of these produce increased tissue stiffness, which should be imageable using elastographic imaging. An inexpensive means of monitoring therapy is not currently available. Ultrasound can see the lesion during the process of ablation, but cannot identify the lesion after the ablation has been completed. MR can identify it, but is very expensive. So what an inexpensive means would be very helpful. The zone of coagulation, being much harder than normal tissue, is readily imaged, as shown in this slide, where a chunk of meat has been ablated locally, and you can see the area of ablation as a slight area of increased echogenicity, but it shows up quite clearly on the elastogram as an area of increased hardness. This is an example in a prostate of an ablation caused by high-intensity focused ultrasound. The outlined area is the area that was ablated, showing markedly increased stiffness compared to the remainder of the prostate gland. Poroelasticity is the monitoring of fluid movement using elastographic imaging. Tissue is not perfectly elastic, but an ideal tissue is perfectly elastic. In other words, when you press down 10%, the tissue moves 5% in one direction and 5% in the other direction, and thus you can, if you take the ratio of strain in the vertical direction versus the horizontal direction, you get a Poisson's ratio of 0.5. In tissue that contains fluid, however, what happens is the pressure pushes the tissue out initially, but the tissue gradually moves back as fluid within the tissue dribbles away out of the field of view. This is known as pitting edema on a clinical examination. On an elastogram, it appears as a decrease in the Poisson's ratio. Thus, the Poisson's ratio will drop from 0.5 down to some lower value in the 0.2 to 0.3 range. The rate of change of the Poisson's ratio can be used to estimate how fast the fluid is moving away from the compartment in question. We hope that this parameter can be used to help evaluate and quantify the amount of fibrosis that is present in tissues with edema versus the amount of actual fluid. MR can be used to evaluate fluid directly, but again, it's very expensive. This real-time sequence shows a poroelastogram as we generate them courtesy of the folks at the University of Texas who are my collaborators. Initially, you notice the image started out as nearly solid red, and solid red on one of these images represents a Poisson's ratio of 0.5. Remember, I said that the Poisson's ratio will start at 0.5 and gradually drift downward as fluid leaves the area being compressed by the transducer. As you can see, the image is gradually turning bluish, showing that the Poisson's ratio is falling down towards 0.1 and 0.2. Thus, the fluid is leaving, but it happens over a very slow time period. This is a several minute examination showing that the fluid takes some time to leave. So it will never be a really fast method of imaging. The rate at which the fluid leaves, we hope, is an indication of the viscosity of the fluid and of the material through which the fluid is escaping. Thus, it may give us an indication of the amount of fibrosis or other impediments to flow that might be present in the tissue. Tissue that is purely fibrotic will be red and will have a Poisson's ratio of 0.5, as it doesn't contain appreciable amounts of fluid. This is an example in a patient with lymphedema of the type of changes we expect to see. Here you can see in the normal arm the 3 images on the top of the slide. If you compress a normal arm, there's very little free fluid in the tissue, and what you get is a Poisson's ratio of 0.5, shown in red here. The arm with edema or free fluid inside the tissues starts out with a lower Poisson's ratio, and as time progresses it gets even lower as some of the fluid drifts away from the area of interest, causing relaxation of the tissues towards the center line and a decrease in the lateral strain. So in conclusion, thanks to enthusiastic creative researchers, the number of potential applications for elasticity assessment technology has dramatically increased, and it's moving into the clinical realm much faster than anyone expected, even myself. Quantitative elasticity applications have been developing rapidly, and now I believe they can take their place alongside the traditional qualitative elastographic imaging as a potentially very important tool for assessment of both tumors and for diffuse organ disease. Thank you very much.